Welcome to the Deep Dive. Today we're tackling a really important topic, one that touches many lives, sometimes directly, sometimes indirectly. We're talking about do not attempt cardiopulmonary resuscitation decisions, or DNA CPR.
That's right.
Our aim here is to, well, cut through some of the confusion, maybe clear up misunderstandings, and really give you the knowledge you need about these significant medical choices.
Exactly. And we're drawing from some detailed sources today, specifically excerpts from Understanding Do Not Attempt Resuscitation Decisions, to make sure we get this right.
Oops.
Our goal, really, is to give you a clear picture.
Yeah.
What CPR actually is, what DNA CPR really means, who gets to decide, and what your rights are.
And responsibilities, too, I suppose.
And responsibilities, absolutely.
Yeah.
Just providing that essential context, because these forms, they're really vital in healthcare.
Right. So let's start with CPR itself. I mean, we all see it on TV dramas, people dramatically brought back to life. But what's the reality? What does cardiopulmonary resuscitation actually involve based on our sources?
Yeah, it's definitely less dramatic and often more complex than portrayed.
Yeah.
It involves really forceful, repetitive chest compressions. That's the core.
Okay.
But it can also mean using electrical shocks, that's defibrillation, trying to jolt the heart back into a normal rhythm.
Right.
And then there's artificial ventilation, maybe using a bag and mask or even a ventilator to get oxygen moving, plus medications often given by injection.
So it's quite an intervention.
Oh, absolutely. A major medical intervention.
And here's something the sources highlight that really caught my eye, the success rate. It says CPR restarts the heart or breathing for only about 1 to 2 people out of every 10 where it's attempted.
Yeah.
That feels surprisingly low compared to, the common perception.
It is. It really is. And the chances depend hugely on the situation. Your odds are significantly better if your organs, heart, lungs, everything were pretty healthy before the cardiac arrest happened.
Okay.
And it helps massively if someone trained is right there and if equipment like a defibrillator is available immediately.
Makes sense.
But on the flip side, the chances drop quite a bit if there's previous organ damage or if you have a serious long-term condition. And the sources are clear. This isn't about just having a disability. It's about conditions affecting organ function.
That's a really important distinction. So not the disability itself, but the underlying health state.
Exactly. Also, things like severe current illness, frailty, or if someone is naturally nearing the end of their life, those factors lower the chances of CPR working.
And what about the physical impact? You mentioned forceful compressions.
Yes, that's another key point. CPR isn't gentle. The sources mention things like bruising, broken ribs are quite common, actually, and even the possibility of a punctured lung.
Wow. Okay.
So it's physically demanding on the body. And even if it does work, even if the heart or breathing restarts, well, the sources say only a few people actually make a full recovery.
A full recovery. So what happens to the others?
They might still be very, very unwell. They might need a lot more intensive treatment, maybe in an ICU. And unfortunately, some can suffer permanent damage, like to the heart or, crucially, to the brain, due to lack of oxygen.
Right.
And that sobering reality is precisely why DNA CPR decisions exist. It's about avoiding a treatment that might just prolong suffering or cause harm, especially when someone's quality of life is already compromised or they're at the end of life.
Okay, that puts it into perspective. So let's unpack DNA CPR itself. We hear different acronyms, right? DNA CPR, DNAR, DNR. Are they all the same?
Yes. Good question. They all mean exactly the same thing. Do not attempt cardiopulmonary resuscitation, or do not attempt resuscitation. The core message is medical staff will not try to restart your heart or breathing if it stops.
Got it.
But, and this is absolutely critical, a DNA CPR decision is only about CPR, just that one specific intervention.
Right.
It does not mean other care steps. You'll still get all the other appropriate treatment, pain relief, comfort care, antibiotics, whatever else is needed and appropriate for your condition.
That's a really common misconception, isn't it? That a DNR means do not treat.
It is, and it's so important to correct. It's purely about not attempting resuscitation if the heart or breathing stops. All other care continues.
Okay. And how are these decisions actually recorded? Is it just a note somewhere?
No, it's more formal than that. It's usually recorded on a specific form. Different places might use slightly different versions, maybe a standard DNA CPR form, sometimes as part of a broader treatment escalation plan, where you might see something called a RESPECT form.
Respect.
Yeah, it stands for Recommended Summary Plan for Emergency Care and Treatment. It's a process that includes recommendations about emergency care, which might include a DNA CPR decision.
Okay.
But whatever the form type, they're designed to be easily recognized by all healthcare staff, doctors, nurses, paramedics. It's kept in your medical records, obviously, but a copy might also be kept with you, say, at home or in a care home, so it's immediately available in an emergency.
And people should know if one is in their record.
Absolutely. It's crucial that you and the people close to you are aware that a DNA CPR form has been completed and is in your records. Communication is key.
Right. This naturally leads us to the decision-making itself. Who decides and how? The sources outline a few scenarios. Let's start with the most straightforward one. When you, the patient, decide to refuse CPR.
Yes. So any adult with the capacity, meaning the ability to understand, weigh up, and communicate their decision, can refuse CPR. This can be at any time, whether you're currently healthy and thinking ahead, or if you're facing illness or nearing the end of life. You just need to make your wishes clear to your medical team.
And can you make that legally binding for the future? Like if you lost capacity later?
You can. That's done through what's called an advanced decision to refuse treatment, or an ADRT, sometimes called a living will. This is a formal document where you specify treatments you want to refuse, including CPR under certain circumstances, if you later become unable to make that decision yourself.
Okay, so an ADRT is the legally binding route for future refusal. And if you make a decision or have an ADRT, can you change your mind?
Oh, absolutely. Any decision you make about DNA CPR can be changed at any time as long as you have capacity. You just need to inform your doctors or nurses, and they'll update your records, essentially canceling the previous instruction. The record might show you had one, but it won't be active.
Good to know. Now, the sources mention a scenario that might surprise some people. A doctor can make a DNA CPR decision even if the patient doesn't agree.
Yes, this is a really important and often misunderstood point. Legally, a doctor doesn't need your consent to make a DNA CPR decision. However, they must tell you that the decision has been made and that a form is being completed or has been. There's a duty to inform you. The only exception is if telling you would cause you significant harm, physical or psychological harm. That's a high bar, though.
And why would a doctor make that decision against someone's wishes or without explicit agreement?
The reasoning comes down to clinical judgment. The doctor believes that attempting CPR would be futile, meaning it wouldn't work, wouldn't actually prolong life meaningfully, or that it would cause more harm than benefit. This might be because, say, organs are already failing badly due to illness, or the person is clearly in the final stages of their life, and CPR would just inflict suffering without a positive outcome.
So it's rooted in the medical assessment of benefit versus burden. Doctors aren't obligated to provide treatment they believe is harmful or won't work.
Exactly. They're not required to offer futile or burdensome treatment. But, and this is vital, these decisions must be made on an individual basis.
Individual basis.
Meaning it has to be about your specific health situation, your needs, your priorities. It cannot be a blanket decision. In fact, the sources state it's unlawful to make group DNA CPR decisions, like for everyone in a particular care home or everyone over a certain age. It doesn't matter about age, disability, race, language. None of that is the basis for a DNA CPR. And importantly, conditions like learning disability, autism, or dementia are absolutely not, in themselves, reasons to issue a DNA CPR.
That's a critical safeguard. It really emphasizes the person-centered nature of this decision, legally mandated.
Yes, very much so.
So what if you disagree? If a doctor makes this decision and you or your family feel it's wrong, what recourse do you have?
You absolutely have the right to ask for a second opinion from another senior doctor. You should voice your concerns clearly. The team should review the decision. However, it's important to understand you can't demand CPR if the clinical judgment is that it would be inappropriate or harmful.
Okay.
The law gives you the right to be involved, to be informed, to have your views heard, and to seek that second opinion, but not the right to compel a treatment deemed futile.
Right. It's a balance between autonomy and clinical reality.
It is.
Okay, what about the situation where someone...
Right. If someone is assessed as lacking capacity for this specific decision, the first thing doctors do is check for any existing legal documents. Is there an ADRT refusing CPR? Is there a lasting power of attorney and LPA for health and care decisions?
And does any LPA cover this?
Not automatically. For an LPA to grant someone the authority to make decisions about life-sustaining treatment, which includes CPR, a specific section in the LPA form must have been completed and signed when the person had capacity.
Ah, okay. So you need that specific authorization within the LPA.
Correct. If there's no relevant ADRT and no LPA with that specific authority, then the decision falls to the senior doctor, who must make a decision in the person's best interests.
Best interests. That sounds complex. How do they figure that out?
It involves consultation. The doctor must consult people who are important to the patient family, close friends, to understand what the patient likely would have wanted. They also must consult anyone with legal authority, like a court-appointed deputy for personal welfare or a parent if the patient is under 16.
What if there's no family or friends?
Then the doctor should involve an independent mental capacity advocate, or IMCA. Their role is to represent the person who lacks capacity. And of course, the doctor considers the views of the whole healthcare team involved in the person's care. It's a holistic assessment trying to determine what's best for that individual.
That makes sense. A thorough process. Okay, let's shift to some practicalities. Once a DNA CPR form is made, how long is it valid for? Is it permanent?
Not necessarily. It depends on the situation. A form might be written just for a specific short period, like during a hospital stay for an acute illness.
Okay.
Or it might be intended to be longer term, perhaps for someone with a chronic progressive condition where their health isn't expected to improve significantly. In that case, it might not have an end date, but should be reviewed if the person's condition changes.
Reviewed how often?
The recommendation is that it should be reviewed whenever the situation changes, like moving from hospital to home, or if there's a significant change in health. The review date or plan is usually noted on the form itself, and if it's made in hospital, it should be shared with the GP when you're discharged.
And is the form itself legally binding? You mentioned the ADRT is the binding document.
Exactly. The DNA CPR form itself isn't a legally binding document in the way an ADRT is. It's a clinical tool, an instruction for medical staff based on either an ADRT, a best interest decision, or a clinical assessment of futility.
Got it. So the ADRT is the legal refusal. The form is the practical communication of that or a related clinical decision.
Precisely. The form ensures the decision is clearly visible and understood by those who need to know in an emergency.
What if someone really doesn't want to talk about it? It's a sensitive subject. Can they just refuse to discuss DNA CPR?
Yes, you absolutely have the right not to discuss it if you don't want to. You can tell your doctors and nurses that, and they can note it down. You can always change your mind later if you do want to talk. However...
Uh-oh, there's a however.
Yes. Even if you prefer not to discuss it, if the clinical team believes CPR would not work or would be harmful, they can still make a DNA CPR decision based on that clinical judgment.
Yeah.
And as we said, they generally still have a duty to inform you that the form has been completed unless that information itself would cause significant harm.
Okay, so you can avoid the conversation, but not necessarily the decision if doctors deem it clinically necessary.
That's the gist of it, yes.
So, last practical point. What should you do if you or a family member are concerned about a DNA CPR form? Maybe you think it's wrong, or it was made without proper discussion.
Okay, there's a clear process. First step, talk to the doctor who made the decision or the doctor currently responsible for care. Raise your concerns directly.
And if that doesn't resolve it?
Ask for a second opinion from another senior doctor. If you're raising concerns for someone else, remember, if they have capacity, they need to agree to you being involved. If the person lacks capacity, then family, friends, or someone with legal authority like an LPA holder can certainly raise those concerns as part of the best interest process.
And what if you're still unhappy after the second opinion?
Well, remember, you can't demand CPR if it's clinically judged inappropriate, but you can pursue a formal complaint if you feel the process was flawed or the decision wasn't properly explained or justified. If the form originated with a GP, you use the GP practices complaints procedure first, then potentially NHS England. If it was in a hospital, talk to the senior doctor or consultant first, then use the hospital's formal complaints procedure, often managed by PL's Patient Advice and Liaison Service.
Are there external bodies for help?
Yes. Local health watch organizations can offer support, as can independent advocacy services. And if you've gone through the NHS complaints process and are still not satisfied, the final step is the Parliamentary and Health Service Ombudsman.
Okay, that's a clear pathway. It's good to know those options exist. Wow, this has been incredibly informative. We've really dug into the layers of CPR and DNA CPR, moving beyond the surface level, just recapping, understanding the reality of CPR, its actual success rates and impacts, then understanding what DNA CPR truly means and what it doesn't mean, and knowing who decides and why. That feels really empowering.
You really should be. Knowledge, when it's properly understood and you can see how it applies, is powerful. Hopefully, hearing these different facets, the different perspectives and processes, helps you think critically about this complex area of medicine.
Absolutely. And it leaves us with something to think about, doesn't it? How does getting to grips with a specific decision like DNA CPR maybe change how we think about broader issues? Things like patient autonomy, what good end-of-life care looks like, and perhaps the conversations we might need to initiate, with our families, with our doctors, even if these choices seem a long way off right now.
That's a profound thought to end on. Those conversations, however difficult, are often incredibly valuable.
For more detailed explanations and related topics, we invite you to watch our videos on our YouTube channel. Don't forget to like, comment, and subscribe to stay updated with our latest educational content. Thank you.